see how it is. Yes, get that on tape.
Oh my gosh, Penner says he has a case.
Oh, no way.
If you need one, I have a couple stored up. If you need one,
Dude, we do need one. I would love for you to present that.
all right.
I'm letting people in, okay?
What's that?
I let everyone in.
Welcome back, Clinical Problem Solver,
Woo!
where you can be mean to Robbie, but be kind to all the other team members. So Robbie, can you show them the sweatshirt that you're wearing right now? Do you guys see how beautiful that is? So this is a funny story. We invested some money in buying these, and originally we had planned to, share it amongst the team members. I wanted a few, but soon realized that it's quite small. So now Robbie is stuck with 10 of these and he doesn't know what to do with them. And I'll be honest, I'm the one who spent the money from our account, which was a total waste of money. But to see him wearing it right, to see him wearing it right now brings me joy to my core. And Robbie, vous voulez manger oatmeal?
Amazing. Yes. Do I want to manger oatmeal? Yes, je veux manger oatmeal. Avec beaucoup de fruits. S'il vous plaît.
Je ne comprends pas. Répétez, s'il vous plaît. I don't know why people are laughing. I'm giving an honest attempt here.
This is pretty good. Why are you learning French?
Oh, so Robbie and I teach in Switzerland, in Geneva, and I feel like I want to be able to communicate with all the lovely people there. And I think, it's like arrogant, honestly, to assume everyone speaks English or should speak English. And so I'm trying hard, folks, but if I end up in Geneva and I'm lost or end up on the news, it's because something went wrong in the language.
By the way, I'm going to save Prof. Rez's image from tarnish because you may think that he's the LA residing attending who was learning French and teaches in Geneva. But I promise you.
I love Deborah's comment, Reza in Paris. I just have an Instagram account.
You should.
But we have an exciting case. If Jack Penner is around and can unmute himself and say hi to the audience, and then I'll pass the mic to Robbie to take us forward.
Hello, everyone. It's great to see you all. I'm very excited to be in the presenter seat for today. Hopefully it's going to be a fun case for everyone to think through.
Is it just me, or is Jack Penner mustache is looking, I'm sorry, you should never comment on anyone's physical attribute, never ever, but they do it on the show, on their show, the space learning episode. And but looking good, Jack. And I actually just saw Jack this past weekend. We had a really extraordinary time in LA. How was your visit, Jack? Was I a good host?
You were an incredible host. I have never had a better host.
Jack was so kind. So I was working a night shift. He bought pineapple. And what was the beverage you bought?
I got you a tropical punch kombucha. No endorsement money coming in here. No endorsement money. But I really wanted to make sure that the pineapple paired well with the beverage. So it was a tropical punch beverage and pineapple.
And then Robbie, you'll love this. Then we watched Liverpool versus Villarreal with some Persian tea and cardamom. How do you pronounce that? It's
cardamom.
Yeah, it's in the book somewhere. But anyways, it was an extraordinary hour.
My favorite was a line I saw on Twitter, which was that two Jacks make a right.
That's what I walk in. We walk into Morning Report on Tuesday, and Reza says hi to Jack Sharp, who's one of the chief residents at UCLA, who presented a case that morning. And Reza just out of nowhere randomly goes, "Two Jacks make a right," and keeps walking.
Oh, the insight into that pineapple fueled Reza brain. It's incredible.
It was amazing. We also had some of the best meals. I had the first time I've ever had Persian pizza, which was delicious.
Oh my gosh, let me tell this story really quickly. So we're ready for some food, Robbie, and we're in Westwood. And I'm like, Jack, this place has hot dogs that remind me of Iran, but they also have pizza that remind me of Iran. He's like, oh, which one should we do? And I said, what would Robbie say right now? And I'm not even joking. He said he wouldn't say or, he would say and. we got a large pizza and 2 hot dogs, and we finished it, and then we both were in a postprandial coma.
I'm glad the or and served you well. I'm really glad.
So the final diagnosis in this case is ileus from overconsumption of pizza and hot dogs.
Well, I'm so glad you guys got to hang out. I can't believe you hadn't met in person before, right? This is the first time you actually met physically.
I think second time because we got to
Oh,
hang
that's right.
out
Yeah,
when
you
he
met
was
in
here
San
for his
Francisco.
visit before.
That's right. That's so cool. Awesome. All right, you want to take it away, good sir?
All right, let's do it.
All
So
right.
this story is going to actually start in the ambulatory setting. It's a 73-year-old gentleman who has hypertension, hyperlipidemia, stage 2 CKD, who was found to have an elevated calcium of 11.7 on labs obtained by his PCP. At that time, he was instructed to increase his water intake and stop his hydrochlorothiazide, which he was taking for hypertension, and then come back a week later for labs again. Basically, 10 days after that, he was found to have a calcium of 12.8 on outpatient labs, a creatinine that was elevated to 2.7, and a hemoglobin of 14.7. Otherwise, had no other major symptoms other than some constipation and malaise, but denied fevers, chills, night sweats, weight loss, abdominal pain, no confusion, no polyuria, no polydipsia. And that's where we will stop.
Absolutely super. What an intriguing space to enter. I'll say that there's so many different ways to approach hypercalcemia. And the first that you'll hear us talk about is to divide it into PTH and PTH dependent and PTH independent hypercalcemia. But the truth is that you often don't have the PTH at the time of your initial analysis. So the question before you is, how do you take advantage of the data you already have? And so I'll reflect on that and then pass the mic to Prof. to layer onto it what he thinks and also just teach us about how he divides that schematic approach that we've talked about. And so the data that you have before you when you get a calcium is usually the history, the physical exam, and the other labs. Presumably, the data was obtained in that traditional order that data is often obtained. So what are the powerful variables to analyze hypercalcemia with that? Oh my gosh. This is the culprit. I have now retrieved it. So what's the data that you have beforehand? Hypercalcemia in a systemic context is very different than hypercalcemia as the center of gravity. The best example of this is hypercalcemia of malignancy. Most patients who have hypercalcemia with malignancy do so in the space of metastatic advanced disease, which usually leaves some sort of imprint on the H&P in the form of chronic subacute to chronic symptoms, cachexia, and localizing features of the original cancer. So usually the center of gravity of that conversation and the exam with the patient will give you some guidance. The other thing to pay very close scrutiny to is the medication list and any possibility of calcium ingestion, especially calcium ingestion with bicarbonate, because bicarbonate facilitates the persistence of hypercalcemia from ingestions, which is called milk alkali syndrome. So in the H&P, you want to get the center of gravity. If it's calcium predominant, it reduces but does not eliminate the probability of malignancy. If the patient is hectic in their hypercalcemia, you should prioritize a malignancy. The other key feature to focus on history is the presence or absence of pain. Why is pain important? Hypercalcemia from malignancy can be paraneoplastic, in which case it would be painless, but often it is neoplastic where the cancer is literally breaking bone, causing hypercalcemia. So the presence of pain is very, very common in patients with direct neoplastic hypercalcemia. And then of practical significance on the exam, you want to pay attention to the degree of hypovolemia. Why? That correlates with the degree of hypercalcemia, which correlates with the cause, malignancy usually. So the point of this conversation is to tell you that where we have started in our CP Solvers episode and CP Solvers schema of hypercalcemia is well beyond where you can start. The problem is all these clues are what are called soft clues. Nothing will supersede the laboratory analysis. Nothing beats a PTH, nothing beats a PTHRP, but there's a mountain of data beforehand to help you make a lot of progress. All right, Prof. Rez, mic to you.
I love that, Robbie. I'm going to try to share a pearl that you shared with me not too long ago during our teaching in Geneva. But before I do that, I want to just talk a little bit about pathophysiology here. And something is really striking. Something is very striking. It's almost like, a patient who has a normal PTH and hypercalcemia is unexpected. So they have hyperparathyroidism. Let me ask the chat, what do you expect the calcium to be in someone who has kidney disease? Do you expect it to be high, normal, or low? This is an important question. Why? Because typically with CKD, you have impaired 1-alpha hydroxylation of 25 vitamin D, and you need 125 vitamin D to absorb calcium from the GI tract. So what ends up happening in patients with CKD, they often have hypocalcemia for this reason. And also, as not at the stage 3, but especially when you get to stage 4 or 5, you build up phosphate, and phosphate also binds calcium. So you get a drop in the calcium. And this is why patients with CKD have tertiary hyperparathyroidism as a mechanism to both excrete the phosphate and increase the calcium. And one of the treatments for hyperparathyroidism is what? Cinacalcet. But sometimes you can't give cinacalcet to patients with CKD because the calcium is the rate limiting step. Why am I telling you all this besides the fact that it's like phenomenal physiology? It's that in most patients, when we see a calcium of 11, we might say, well, it's mild. It's not that significant. But in a patient who already has a barrier to calcium homeostasis, this delta may be more significant than a patient with a healthy kidney. So I'd be very curious to what the calcium was previously to see if this is a larger delta than Robbie and I are expecting. The other interesting thing is calcium through the mechanism of nephrogenic DI leads to hypovolemia, which can lead to prerenal azotemia, can lead to AKI, and can lead to hemoconcentration, and why we probably see this hemoglobin of 14.7. Now, the last pearl I want to share with you is like something that Robbie taught me that was sort of mind-blowing. So you know how a patient comes in with hypercalcemia, we send the PTH, but it doesn't come back quickly. And in the same moment, we end up sending a 125D and a 25D. And we might get those labs before the PTH. And we get the labs and we say the 125D is elevated. So everyone's like, there must be a granulomatous process because the 125D is elevated in the PTH. But don't forget, it's not only granulomatous processes that cause an elevation in the 125D. What does PTH do? One of the mechanisms of PTH is to act on the kidney to stimulate the 1-alpha hydroxylation. So in hyperparathyroidism, you'll also have an elevated 125D. So don't ever rush the process. The first step is the PTH. We might get into the chloride phosphate ratio, which is one of our favorite laws of electrical neutrality, but we'll slow down for now and get more data from Jack. One last comment I'll say, Jack, the treatment of these clinicians was phenomenal. Like, you have a medication that's probably causing the problem. It's like in someone who has mild cognitive impairment that's on alcohol, you tell them to stop drinking, let's see what happens. This is the same scenario. You have a good reason. It's not that high. Let's stop it. And the patient has kidney disease, probably not the best drug. And let's see what happens. But you keep the door open for the patient to come back to the hospital.
I love it. I will go ahead and take us a bit of a ways forward here. Just one clarification. I misspoke. The patient has stage 2 CKD, not stage 3 CKD, but that should not take away from the brilliant pearl from AMK about CKD stages and the anemia that can develop. But just to clarify, for this gentleman, it is stage 2 CKD. I wish that I was smart enough to know to check the prior calcium before preparing this. I was not, but I will do that in the future. Thank you, Rez.
No,
And,
I think you were smart not to check it, Jack.
We can just say it was low-ish. Let's just like say it was previously low-ish for the sake of the argument here. In terms of the other past medical history, there is nothing revealing. In terms of the meds that this patient is taking, he was on atorvastatin, took some topical diclofenac gel PRN for joint pain. and then occasionally used ibuprofen. In terms of his health-related behaviors, 1 to 3 alcoholic beverages per week, but otherwise no tobacco use. Social history, I will not go into details for just for patient privacy, but it is not relevant to the final diagnosis. And then allergies, no known allergies. In terms of his exam, vital signs were totally stable. Notable elements of his exam were dry mucous membranes, but otherwise his exam was completely normal. And then the initial labs that were obtained, the patient was sent to the emergency room after this worsening hypercalcemia was developed. And I can give you the initial labs in the ER, which included a CBC with a white count of 8.3 and a normal diff, a hemoglobin of 14.5, platelet count of 245. Metabolic panel, the sodium was 136, potassium 3.8, chloride 104, bicarb 18, BUN 48, creatinine 2.8, baseline is 1.6. The calcium was 12.9, phos 4.1, mag of 1.8. Liver enzymes had an AST of 36, an ALT of 42, an alk-phos of 96. Total protein 7.2, albumin 4.2, and had an INR that was normal at 1.1. And then I can give you a chest x-ray that showed multifocal interstitial opacities. And then his EKG showed sinus rhythm with first-degree AV block. That first-degree AV block was technically new, but his last EKG was from 4 years ago.
It's time for some magic.
I just want to also applaud Jack, the way he's presenting. You see how slow he is, like waiting for the scriber to get the data on the whiteboard, which is like really nice. Thank you, Jack. Robbie, why don't I leave the background, the social history and vitals and exam for you, and I'll comment on everything else. I'm just joking.
No, can you believe he's this sharp after working overnight? He's after an overnight shift. You know how dangerous this human being is when he's full throttle? This is after a whole overnight shift. All right, go, keep going.
All right, but okay, so I will just comment on the labs, leave the imaging and everything else for Robbie. Recently on an RLR episode, Robbie discussed a case I presented to him of chronic opacifications in the lung, and it was just phenomenal. I presented the same case to Jack when he was visiting at the poolside on the rooftop of his hotel, and their discussion had a lot of overlap, which was phenomenal to experience as a case presenter. When we get to these labs, I think what my attention goes to, honestly, is to see if this disease or this entity that's causing the hypercalcemia is leaving a signature anywhere else, in the kidneys, in the liver. And we know the kidney issues is likely a byproduct in part of the hypercalcemia because of that nephrogenic DI and the hypovolemia that accompanies it. I was also looking at the bicarb to make sure that the patient didn't have a concomitant metabolic alkalosis. That would prompt me to think about the milk alkali syndrome, which is probably the third most common, or it's not that uncommon of a cause. Base rate always has hyperparathyroidism and some form of malignancy. Then I quickly calculated the chloride to phos ratio. So let's talk about electrical neutrality. When you have high PTH, PTH is the phosphate thrashing hormone. If you're losing phosphate, which is a negatively charged anion, you're going to reclaim chloride. So if you look for a chloride to phos ratio, what would you expect it to be if it's due to PTH or PTHRP, right? If you're losing phos, so you're lowering the denominator, you're increasing the numerator. Thank you, Hans. You expect it to be elevated, usually north of 35. I think we have to be a little cautious because I don't know in that one study how many of these patients actually had CKD stage 2, which we know is a cause of hyperphosphatemia despite PTH. But if it applied to such patients, when you look at this ratio of 25, you would say this is a non-PTH, non-PTHRP mediated process. Though, again, I'm being cautious here because I don't know how CKD affects the phos and the ratio we might anticipate. Ultimately, we need a PTH, but let me give the mic to Robbie to guide us further.
That is absolutely superb. You know, I love that. I love that pearl. And then I think every pearl has to come with a caveat. Honestly, that's probably the higher order teaching of these pearls. And I love that. I forgot about how the kidney influences that analysis. You know, I know you wanted me to talk about the imaging, and I think the imaging, I would say, is a clue to what's going on. And if I'm being transparent, the most striking lab here is the hemoglobin. Let me make an argument as to why. So I think if you ask yourself, what is the pretest probability of a PTH mediated hypercalcemia here? You follow Reza's argument, you're like, okay, it's already low because of what Reza said about the chloride phos ratio. And then I would say it's much lower for two other reasons. First, this is the wrong demographic to get primary hyperparathyroidism in terms of age, older than usual middle age, and also in terms of gender. And so that reduces the likelihood. And what further reduces it is this is what you can happily call hectic hypercalcemia. What does this mean? This is hypercalcemia that has resulted in overt consequences to the patient in an acute manner. The height of the calcium, the amount of hypovolemia are the two biggest reasons to call this not so much chill hypocalcemia, but hectic hypercalcemia. So the probability of a PTH mediated disease is super low in hectic hypercalcemia. Now you ask yourself, what else is left, right? What else is left? And if you pull up the CP solver schema of what else is left, all of it doesn't sound any good. There's some exceptions, milk alkali, but that's probably not a play given the bicarb. So when we're saying that what's left after you exclude PTH and you reduce milk alkalis, what you're really saying is I'm worried about a malignancy. Really? What kind of malignancy can cause a calcium this high but a normal hemoglobin? I've never met one. Why? The rule of thumb is that hypercalcemia is usually an end-stage manifestation of malignancy. In fact, it is a criteria that often gets patients to meet hospice because the prognosis of cancers presenting with hypercalcemia is less than 6 months. By the way, Deborah, I love that caveat. It's none by Robbie, but maybe the crowd can come up with some. I think that's very important. So you may ask, wait, hold on. What, you have hypercalcemia and AKI. What about multiple myeloma? And I will tell you the chances of multiple myeloma are super low. Why? Because multiple myeloma begins in the opposite way that mnemonic we know of. The mnemonic is crab, but it actually begins as bark. First bone lesions, then anemia, then renal insufficiency, and then hypercalcemia. So the presence of hypercalcemia with a normal hemoglobin essentially excludes multiple myeloma. And I would say it excludes most cancers. What kind of disease can cause hectic hypercalcemia yet maintain a normal hemoglobin? Well, that's where the X-ray and the EKG comes into play. You might say, what does multifocal interstitial opacities say? What does that represent? It could represent many things, but in this specific context, you worry that it might represent cancer. But when you layer in the EKG findings, it helps us zero in on a very specific kind of diagnosis. Now, I'm going to be authentic to what happens in real life. In real life, I think you should think this diagnosis, but swallow it and keep it inside, because you might be at risk of invoking something relatively unusual too soon. So I'm not going to say it out loud, but I think you have enough data to suspect it now. But here's what I think we ought to do. We ought to wait for the PTH. We ought to wait for the PTHRP, because the laboratory analysis of this diagnosis cannot happen with PTH and PTHRP cooking, as Reza taught us before. So I think you hydrate this patient, you get your PTHRP or PTH, and you let the story evolve. But the normal hemoglobin here really provides a powerful filter for this diagnosis. And the final clue that I think we'll need in this case is a very close exam of the face, looking at the eyes, looking at the parotid glands, and looking at the skin for very subtle clues of this very intriguing thought. It's a thought, we'll keep it in our back pockets. The biggest takeaway I say is a hectic hypercalcemia with a normal hemoglobin. There's not.
Dude, let us know what you're thinking, man. You have all of us on the edge of our seat.
No, I won't. I don't think it's real. I don't think I would do it in real life. So I'll come back to it. I promise. And hopefully it's wrong, because if it's wrong, it'll reinforce the notion that at the end of the day, even if your script is matching a rare disease is very rare, period. So I hope I'm wrong, but I promise I will tell you what I'm thinking, even if we're wrong. Okay? Deal?
That's why we call him the Riddler after the mathematician. Play me a riddle.
All righty, JP. Mic to you, my friend.
All right. So the way that this played out in real time was that with these chest x-ray findings, as you are mentioning, we got a CT chest without contrast. That showed diffuse, bilateral, symmetric, perilymphatic nodules, mediastinal lymphadenopathy, and then on the cuts through the upper abdomen of the CT chest, there was numerous hypodense liver lesions that were seen in the parts of the visible abdomen, but those were incompletely characterized because it was a chest film. The other labs that we got back fairly quickly was a PTH that was low at 2.8, a serum free light chains that were had a kappa light chain level that was 37.9, which is high, lambda light chains 31.5, which is also high, but the ratio of kappa to lambda was 1.2, which is normal. Had an SPEP that showed no paraprotein, a UPEP that showed no paraprotein. And those were the things that sort of came back within the first couple days. And then some of the other labs were still cooking. So I'll pause there.
Awesome. Well, I'll tell you all, I can't wait for Robbie to share the answer to his riddle, but maybe I'll comment on some of these other labs and then I'll pass the mic to Robbie to take us home. I will say that it's nice that the PTH is low, because we weren't suspicious of a PTH mediated process for a number of reasons. The age of the patient, the chloride to phos ratio just made it unlikely. The kappa to lambda ratio is not unexpected. In fact, in patients who have kidney disease, usually ratios above 5 is when you should be concerned for a monoclonal gammopathy or light chain disease. This is keeping within what's expected in the context of kidney disease. I think what's most intriguing here is the pulmonary nodules, the lymphadenopathy, and the hypodense lesions on the liver. And the question becomes, which one do you use as your center of gravity to make progress on the differential diagnosis? Honestly, it doesn't matter. I would suggest you use the finding, whether it's the lymphadenopathy, the nodules in the lung or the liver, the one you're most comfortable with, and then cross-check it with the other findings. But obviously now the hypercalcemia is less concerning. It's just a result of this underlying disease process. And now when you're approaching the lymphadenopathy, you ask the question, what can cause lymphadenopathy and hypercalcemia? With regard to the lymphadenopathy, the common causes of lymphadenopathy that we often think of, like HIV, Sjogren's, mononucleoses, these don't cause hypercalcemia. This is where you really have to think about malignancy and a do not miss diagnosis would be something like lymphoma. But then you ask the question, can lymphoma lead to nodules, pulmonary nodules? And the answer is it can. In fact, it can. It can involve the lung, the lymph nodes, and the liver. But then you look at that CBC that Robbie mentioned, and you're like, well, where's the thrombocytopenia? Where's the cytopenia? Where is the, the night sweats? Where is the weight loss? But truthfully, one of the most common findings of lymphoma will be lymphadenopathy. Lymphoma has a cousin, and that cousin is something you always have to consider when you think of this specific diagnosis. In fact, I would say probably two cousins. One other cousin would be some kind of endemic mycosis, which would be a totally perfect fit for lymphadenopathy, pulmonary nodules, liver nodules, and through 1-alpha hydroxylation and granulomatous mechanism can lead to hypercalcemia. So I guess maybe I'll leave the third cousin for Robbie to discuss, but I think with this imaging, I'm very interested in a tissue biopsy. I would prioritize the safest site, and I would go for, at minimum, a core, if not an excisional, if it were doable. And I would probably target the lymph nodes, and there I would study it for cancer, do a flow, look for adeno, but also study it for fungal disease. And then one other diagnosis that I think Robbie was considering early on, which I honestly didn't think until the imaging came back.
Yeah, maybe because you've given me so much practice thinking about this diagnosis in the last 48 hours. I'll just leave it at that. So, folks, at the end of the day, why are we doing this VMR? We're doing this VMR so we get some practice. And I think that we're doing this so we can learn from each other. And I've been scrolling through the chat, and I think the chat is going pearls galore, reflecting on endemic mycoses, reflecting on subtle lab changes. And so I feel like for the folks on YouTube, one major reason to join us live is to hear the wisdom from the chat. I wish I could repeat that. And I think that, I think real life is complicated because real life, you're so burdened by the morbidity of missing the no misdiagnoses. And the chat is essentially summarizing that the no misdiagnoses are endemic mycoses like histoplasmosis. And Reza is reminding us that, hey, in an older adult, cancer looms large. And I'm struck by three features that I think are specific enough that when you walk into this patient's room and say, hey, I think we need to biopsy, and you're telling them, hey, cancer is on my DDX, a pretty bad metastatic infections on my DDX. I think that you can walk into this specific room and tell them, hey, I'm actually a little bit confident that we're going to be okay. The goal of this reasoning is not to prioritize one differential diagnosis. Take it to, how is it actionable? It's actionable to inform your pre-test probability of what those biopsy results will show. So let me make an argument as to what that is. The nature of the pulmonary nodules is very important. And Dan, Jack, and Anna Fretz worked very hard with Lakshmi Santosh to come up with an amazing schema that's actually available on the website. This schema is only applicable to patients with multiple nodules. So we're not talking about those solitary nodules, we're talking about multiple nodules. And they come in three flavors. Hematogenous or randomly distributed nodules, perilymphatic, and peribronchial. Peribronchial nodules means that it's right next to the bronchus, which usually means they spread through the airway. Vascular nodules is perivascular, means that they're hematogenically spread. And perilymphatic means that these nodules are actually spreading through the lymphatic system. Now you have to be careful because you need to have a lot of trust in your radiologist for them to be confident, because we're literally talking about millimeter differences. Millimeter differences. What is the differential diagnosis of perilymphatic nodules? It's actually very narrow. It's one of three things: sarcoidosis, lymphoma, or metastatic solid tumor. And here's where that hemoglobin comes back again. A metastatic lymphoma and a metastatic solid tumor with a normal hemoglobin is possible, potentially through invoking EPO-mediated paraneoplasia, but it is very rare, very rare. Okay? So when you just say perilymphatic nodules and a normal hemoglobin, you should just run to sarcoid. And how can you run even faster? Metastatic malignancy to the endocardium is very rare. Cancers tend to cause conduction system disease. You probably won't hear of a lymphoma or a metastatic solid tumor causing a conduction system issue. You will hear about them causing pericardial issues, but not so much conduction system issues. So if you assume that this heart block is related to this disease, which it's not definitively, it could be age-related conduction system disease, you again go to that, go to the sarcoid hypothesis. And what further reinforces it is the sarcoidosis's propensity to cause disproportionate conduction system disease. So not only do you say that cancer would be very unusual, it's that sarcoid would be very usual to do this. And the nail in the coffin is the kidney manifestations. So of the organs beyond the thorax that sarcoid goes to, it has a high propensity to go to the kidney, where it causes a granulomatous interstitial nephritis. So here, what would I do? I think the number of patients with sarcoidosis who have subtle swelling of their parotids, who have subclinical evidence of uveitis, is actually fairly large. The clues for this diagnosis tend to be in the face. So what would I do in real life? I think I would go back to being practical. Reza said it, we have to get biopsy. You cannot diagnose sarcoid with only 3 exceptions unless you have non-casein granulomas. So you need to find those non-casein granulomas. But what would I do in real life? I would be looking for them. I would tell the patient that the probability of sarcoid is high, but we have to rule out cancer and endemic mycoses. And I would be looking very closely and maybe even asking ophtho to look at the eyes and to look closely at the parotids to see if there's some subtle parotid swelling. So that's why I'd prioritize sarcoid. But I'll pass the mic back to Professor to see if anything else to add, or JP to take us to the next output.
As zero to add, and I just think that's so powerful to use that filter of a normal hemoglobin, and yeah, I think that was beautiful.
All right, this is an absolutely phenomenal discussion. So the next series of things that came out was to better characterize this intra-abdominal pathology. Patient got an MR abdomen with and without contrast, and that showed innumerable T2 hyperintense nodular lesions scattered throughout the liver, with a few additional lesions throughout the spleen, and prominent upper abdominal lymphadenopathy. There were also a few small sub-centimeter lesions within the lumbar vertebral bodies that were thought to be due to a similar process as what's impacting the liver. The 125 and 25 vitamin D levels came back. The patient had a 25 vitamin D that was normal and a 125 vitamin D that was high. Ultimately, the patient underwent an endobronchial ultrasound with initially an FNA of one of the mediastinal lymph nodes. And that came back showing non-caseating granulomas, gram stain, acid fast, and fungal stains of the lymph node showed no organisms. Patient underwent basically evaluation of their sputum for Mycobacterium tuberculosis, had 3 negative AFB smears and a negative PCR, and then also had negative serum and urine testing for coxine histo. So a negative histo urine antigen and negative serum coxy studies. And then I will give one more piece of data for now, which is that there was a lot of question about whether or not what's happening in the chest is the same thing as what's happening in the liver. So the patient also got a liver biopsy of one of these liver lesions, and that also showed non-caseating granulomas.
You know, I think I'll just say I'd love Prof. Rez to analyze this since I rambled so much in the last aliquot, but I'll say that I think the degree of disease burden here should cause alarm, right? I mean, I think this person has lesions in liver, bone, spleen. And so you should back now with this data, you're like, wait, this patient was minimally symptomatic before. He didn't complain of abdominal pain, didn't complain of weight loss, didn't complain of night sweats. And yet I'm seeing a disease imprint that is way out of proportion to what he was feeling or describing. And so now you have to step back and say the data that I was using to come to the hypotheses, I was essentially using the hemoglobin as a proxy for minimal disease burden, right? But now, and that was supported by the fact that the patient didn't really come in describing months and weeks of symptoms. But now you have to step back and say, hey, is our hypothesis put in question? And to be authentic, I'm having a kind of an interesting realization, which is to say, if the patient is having extensive disease burden, but does not feel it, and it hasn't impacted his hemoglobin, is that a clue that it's actually a more benign diagnosis despite its spread? And I don't know the answer to that. I have to think more about that. But my reflex response to this data was, this is a lot more than I expected. So it certainly pushed me away from the most benign hypothesis of sarcoid. But then I thought, wait, it's everywhere, and yet he's kind of okay symptom-wise, and his hemoglobin is still okay, presumably. So actually, does it counterintuitively reinforce that? And I haven't thought about it long enough to know the answer to that. But those are my reflex 10,000-foot view of this data, but I'll pass the mic to Prof. Rez for his thinking and more.
Thank you. And Jack, let me ask you, was this patient a smoker? Did this patient smoke tobacco?
Non-smoker.
And not overweight?
Not particularly.
And the reason I'm asking these questions, the same way we viewed the delta in calcium as being more significant in someone with CKD, your starting point of hemoglobin may be higher in a patient, that may be smoking or have OSA. And so the 14 may in fact be low compared to where they originally lived. But all that being said, I think, Robbie, where I am, I'm right there with you. I think we really have to look for lymphoma, and this would be like the whole concept of script flexibility, just given the extent of the disease. I feel more comfortable saying that this is not an endemic mycosis based on the pattern of imaging findings and these perilymphatic nodules and the serology and the urine test. What I don't feel comfortable with just based on an FNA is dismissing lymphoma. I used to think that lymphoma always had to have a cytopenia, but then I think we had a few VMR cases, and I talked to Anand Patel, and he said that it's not necessarily the case. I think right now I'm also uncomfortable because I've never seen sarcoid this aggressive in the liver. I have in the bone, Rob, but we've discussed so many cases, bone and lung. So where I am, Jack, to be frank, is to want an excisional or like a core or something and do a peripheral flow. I think we must exclude lymphoma here. But I don't think any of us can make a confident diagnosis until we go down that route. I mean, this is all fun. It's an exercise, but we just need a good amount of tissue where everyone feels comfortable saying that we've dismissed, lymphoma.
Amazing. All right. So 2 pieces of data coming your way now, and then I'll give you all the final diagnostic test. So the decision, like exactly as you all are so brilliantly articulating here, there was a lot of conversation around, what do we make of the non-casing granulomas? How do we hold this in the context of this being an FNA rather than a core or an excisional lymph node biopsy? And so what ultimately happened is the thought was, well, we should try to get an excisional lymph node biopsy, but all of the ones that we're currently seeing are too difficult. Most of the lymph nodes in the upper abdomen were abutting the aorta, which would be a very morbid procedure for this gentleman to go through. And so the decision was made to get a PET CT scan to see maybe we'll find a hypermetabolic lymph node in the axillary area or in the supraclavicular area that may be amenable. The morning that the patient was supposed to go to a PET CT scan, was found to have asymptomatic bradycardia into the 40s and was having episodes of Mobitz type 2 that was also flipping occasionally into 3rd degree AV block. So that delayed things by a couple of days, but ultimately got a PET CT scan that showed no real more easily accessible lymph nodes, but the PET CT did show that there was effectively multiple areas of mediastinal, retroperitoneal, periportal lymph nodes. So diffuse hypermetabolic activity in the lungs, the liver, and lymph nodes extensively elsewhere. The vertebral lesions also really lit up on the PET CT scan. And so the decision was made to go for a biopsy of one of those vertebral lesions, which will ultimately reveal the final diagnosis.
presented like an artist, to be honest. So Robbie, let's dance here. I think you made a point earlier on in your discussion saying that you basically use the illness group of sarcoid and cancer and lymphoma, and you're like, well, sarcoid commonly involves the heart. And here now we're seeing significant conduction block, which wouldn't be ordinary aging. And so if you put the frequency of sarcoid versus lymphoma, which one involves the heart, sarcoid is by far more likely to involve the myocardium, the endocardium, and cause these findings. Though in very rare instances, I've seen read in NEJM of lymphoma also infiltrating the heart. But given that's so rare, like I'm okay with saying that maybe this sarcoid is more aggressive than the usual sarcoid because of the cardiac manifestations. And I'd just be interested in your thoughts, Robbie, like how what you're thinking. And yeah, and it seems like the team wanted to go for additional tissue to confirm that there isn't, you know, a lingering lymphoma or, you know, endemic mycosis. But what do you think, my friend?
You know, I love that point. I think, you know, these cases are amazing because they come up a lot, these kinds of themes, and they come up a lot because I think that at the end of the day, there's no definitive way to know for sure that the diagnosis of exclusion sarcoid is not being diagnosed because you failed to exclude the infection and the cancer. So you are all constantly applying your clinical reasoning to its maximum potential, because the only way to diagnose sarcoid is to rule out the other things, one, and two, there is no definitive test that rules out the two other things, right? So you're always constantly juggling. And so I think the cardiac manifestations break the symmetry here and make it much more likely to be sarcoid. But again, applying the practical lens, what just happened now when your patient has advanced cardiac block is your treatment threshold just dropped. It's no different than when somebody has cancer and you're worried about it and they develop tumor lysis. Your treatment threshold has dropped, meaning that now, unlike before, your need to do something more specific has skyrocketed, right? And so do I think this is sarcoid? Yes, for the reasons that we outlined. Do I think this could be lymphoma? Absolutely. Why is it less likely? For the reasons that we believe in sarcoid, but also because of one thing that you taught us on the Patreon videos, which is the one cancer that does this is usually Hodgkin's lymphoma, not any lymphoma, and Hodgkin's lymphoma spreads contiguously. And here, the extent of the disease without contiguous spread is another ding against the most common competing lymphoma, which is Hodgkin's. And so I think, what would I do in real life? I'd be like, oh, we probably need to get more tissue. But I wonder, should we start treating this patient with steroids and seeing what happens? And I'll tell you this, if you give this patient steroids and they improve and then get worse again, it's not sarcoid. If you give this patient steroids and they improve and they improve and improve and improve, it's sarcoid. So for me, what has really happened is the treatment threshold has been reached because of the morbidity of untreated cardiac conduction system disease. And I would use treatment as a diagnostic test. Pending that final biopsy. So that's where I would lie authentically. All right, JP, Mike to you.
All right. So the patient got basically a bone marrow biopsy of at the area where the vertebral lesions were, and that showed a low-grade CD5 positive lymphoproliferative disorder that was involving about 20% of the marrow in that area. Flow cytometry of that specimen was compatible with something called a marginal zone lymphoma, which is an indolent non-Hodgkin's lymphoma. This played out sort of over the course of another few months, where the patient had fluctuating renal function. So ultimately, a renal biopsy was pursued, and that also showed non-Hodgkin's lymphoma involvement of the kidney as well. So the final diagnosis was ultimately an extranodal marginal zone lymphoma. But as you all are saying, like, none of this, so many of the other features of this don't make sense for a lymphoma or for a lymphoma alone. And so ultimately it was thought that this patient had a non-Hodgkin's lymphoma that was complicated by a sarcoid-like granulomatous reaction that caused so many other of these findings. And one of the reasons that I loved this case so much was that, Robbie, I think your point, for those of you who haven't listened to Sunday's RLR, please go and listen to it. It is a phenomenal discussion. And I think what was one of the reasons why I love, or why I wanted to present this case today, is that the sarcoid lymphoma relationship oftentimes goes in the direction that you shared, Robbie, on Sunday of sarcoid leading to lymphoma. But then there's the reverse relationship that can very rarely, but occasionally develop, of lymphoma either preceding or occurring alongside a sarcoid-like reaction, which is what was thought to be the case here.
You witch. I'm just joking. That was amazing. What an exercise. Jack, what did they do for the conduction abnormalities? Did the patient get any intervention for that, or just the treatment of the sarcoid-like reaction?
Ended up getting a pacer placed.
Got it. Okay,
Yeah.
that makes sense. Got it. All right. Well, thank you so much for presenting this. I'm going to give the mic to Robbie. And I honestly, my reflection is that you just got to be very, you have to be very cautious and careful about diagnosing sarcoid. But none of this, the final diagnosis, takes away about what the most likely diagnosis was, for like the eloquent reasons that Robbie outlined in his discussion. So yeah, I don't know, Robbie, how do you feel?
You know, at the end of the day, I think this is so humbling. I think the fact that what we're saying and what we've learned is that you're trying to diagnose sarcoid, but you also have to entertain the possibility that there is a if I'm hearing you right, Jack, you're saying that there's a lymphoma that triggered a sarcoid-like reaction, which is so humbling to me. And I think the only truth you can take away from these cases is that you can stretch your reasoning as much as possible, but at the end of the day, you're leaning on pathology. And what your role is how hard you push for that pathology. And some cases are so classic for sarcoid, like Hereford syndrome or Lofgren syndrome, that you don't even need pathology, right? There's one end of the extreme where somebody presents with fever, bilateral hyolymphadenopathy, and erythema nodosum. The textbook will tell you don't even get a biopsy. And then there are cases like this where how many biopsies did we get? 2, right? 2 or 3? 3. So it took the third biopsy to actually clinch this diagnosis of lymphoma. So I think that at the end of the day, these are the cases that we love the most, that make it most often in these NAGM CPS exercises, because the only thing that you know for sure is you have to be constantly thinking. You can't let it go. And I think that it is really the credit to the treating team to constantly thinking and saying, hey, I need to push harder for that third biopsy. And if I were taking care of this patient solo, I probably would have made a diagnostic error. I probably would have treated him for just sarcoid. And then, but what I probably would have done is, hypothetically, his lymphoma would have emerged more vigorously and then caught it later. So I don't think I would have missed it completely, but I probably would have been delayed by months. And it's humbling to know that. And it pushes you even further to try to see, okay, what's unique about this case that would have caused that?
Robbie, jumping off of that, like we know sarcoid involves the liver, right? We've seen it, we think, but I've never seen it macroscopically like this on all the cases we've done, to leave such an imprint. I don't know. I mean, Jack would know more than me if that may have been a significant red flag to say that this is just all sarcoid.
I would just say that the like conversation that is unfolding here is mimics with much more, and I think adds much more nuance to like what was so challenging about this case. Like I would say this was from when I was an R2, so we'll not pretend that I have near the expertise that either of you or the chat has in terms of thinking about this case. But I was sort of like defiantly of like, this is sarcoid. Why are we still messing around? Like, this has to be sarcoid. Like, all of the features are there. Can we just give this person the steroids and have them follow up? And one of the one of the pulmonology attendings, what she said is she's like, we have to reconcile the fact that somebody who's 73 years old has new sarcoid that is this extensively involved. That epidemiologic factor is what led them to push really hard for biopsy after biopsy after biopsy to feel like we could really falsify all of the other diagnoses to formally diagnose sarcoid. And I think I bring this case not because I think that it's necessarily a solvable case because of all of the reasons that you all mentioned, but it highlighted that sort of kind of terrifying reality of like, when actually have we like ruled out everything else? Because I think it was really, really humbling in this case that I was like saying to my team, like, we can get this other biopsy, but I think we're just going to end up in the same space. And then when the flow came back, I was like, oh my gosh.
That is such a brilliant point. The age is, I completely, like, that didn't come into my analysis. I'll speak for myself, my analysis at all. I completely forgot about that. That is so powerful. And it goes to show you how like you can get entrapped in a certain hypothesis and not escape it. But the age is a big, big red flag. And thank you. I'm so glad you raised that at the buzzer. That's so cool. I honestly, I could talk about this case forever. I think it probably will be talked about forever amongst the subset of legendary VMR cases. So really, really appreciate you bringing it here today, Jack. I see Reza's like leaning back and thinking. So we'll pass the mic to the team, all three of you, to do the teaching points.
Hello, everyone. Amazing case, Jack. Thank you so much. And I want to say thank you for the team, Madeline, that is a machine scribing. You did great. And Shema and Sammy, that really helped me to catch everything. So going for the teaching points, the hypercalcemia, we can think about when is PTH dependence or independence, and think about the context that can be different if it's systemic or the center of the gravity. And the CKD can cause a impaired 1-alpha hydroxylation and can cause hypocalcemia, phospho-binds calcium, and then a tertiary hypoparathyroidism, and then can increase the calcium and get low the phosphate. And hypercalcemia can cause a nephrogenic DI, a hypovolemia, a AKI, and then a hemoconcentration. And thinking about the 125 vitamin D, we think about the granulomatous causes, and then exogenous vitamin D, lymphoma, and hypothyroidism. And the milky alkali syndrome, it's like a high level concentration of calcium in the body and can cause too much calcium, can be caused by too much calcium supplement, like usually calcium carbonate, a high vitamin D, and a calcium deposit is in the kidney. And the injection can cause you by the injection of the calcium bicarbonate, and can cause the metabolic acidosis. And the multiple myeloma, we have the pneumonic crab, but we have to think about BARC because it's the bone lesions that can cause anemia, renal failure, and then the hypocalcemia. And then Robbie said that a malignancy in normal high hemoglobin, he doesn't know any causes. And the lymphadenopathy.
Deborah, strike that from the record.
Take it out, take it out, take it out.
Okay, I'll change, I'm sorry. And the lymphadenopathy and the hypocalcemia, we think like a malignancy like lymphoma that can cause the pulmonary nodules and can happen without cytopenias. And can mimic granulomatosis like a fungal or a histoplasmosis. And the sarcoid normally involves the heart, and that means that can be more aggressive. And the final part is that lymphoma can trigger a sarcoid-like reaction. So thank you so much.
Deborah, that was phenomenal. Excellent job teaching. Sorry for the interjection. I do have to just mention something that's more philosophical right now. I'm not mentioning this because of Rob, because Robbie doesn't need any reassurance. We all know he's the maestro, but I've been recently introduced to John Wooden by Jack. And John Wooden was this phenomenal coach at UCLA that won 10 NCAA championships. And he actually considers himself first a teacher and then a coach. And something that was highlighted during my night shift here, and I watched a bunch of videos with like the music in the background where you start tearing up and thinking you can accomplish anything in this life. But John wouldn't stress, it's not so much about the outcome, but it's more about the process. And he really lived it. Like a lot of people say that, but few live it. If you go back and you analyze this conversation, 99.9% of the time, what Robbie had said holds completely true. But we learn in medicine, there's always rare exceptions. So I mean, I'm not just saying this to bring comfort because Robbie doesn't need any comfort, but it's the truth. Like I love the discussion. I'm going to use that pearl about the hemoglobin. I'm going to make it my own next time we go discuss. And I'm very shocked actually with this final that it just will, I'll probably put that caveat that like very rarely you can get this extra marginal zone lymphoma that's CD5 positive. But Robbie, any reflections on that?
I have two short reflections. One, I appreciate you very much. You're very kind. I think a small part of your heart is saying that because you're an incredibly kind human being, though 99% of it because you believe it. But I don't believe for a second that a small part of it isn't because you're too kind, and at least a little bit worried of the mild embarrassment that I've caused myself. But the truth is, I don't feel any. I really don't. Like I think and I probably would feel a lot in many different spaces. I don't feel any because I feel so comfortable around you all. And, on last Saturday, we talked about like, hey, even when you don't know, go for it. The only time to learn is when you go for it and you're wrong. And, before today, I definitely would have said that, oh, a normal hemoglobin rules out cancer for sure. I would have said that. And if I hadn't mentioned it so deliberately today, I probably would have never learned. Probably wouldn't even have made the association today. So I fell flat on my face. But I think when you fall in VMR, it's like a bouncy castle, and it hurts for like a microsecond, but you bounce right back up. Especially when Prof. Ress is behind you saying, "Hey, it's all good, everything's fine, nothing happened here." Thank you all.
It was poetry, honestly. I wouldn't change a thing. But all right, everyone. Take care now. Have a wonderful day. Robbie.
Thanks, JP. That was awesome. Absolutely brilliant case. Thank you.
Yeah.
Oh
thank
my
you,
gosh,
Jack.
of course. Thank you also. I was saying, I think like the nuanced discussion and just the level of detail that you all were able to extract out of it. And I think, again, like this is one of those cases where I thought about this case that like thousands of times. Yeah, probably thousands of times since we first saw it. And I think it is one of those examples of exactly as you're saying. You roll the dice on this 1,000 times, and 999, it is not what the final diagnosis was in this case. And I think the way that you all hung on to the probabilistic reasoning, I think is the most emblematic of what we can all aspire to, which is to hang on to probabilities and be so rooted in the principles of the reasoning process, and to stay so authentic to that was, I would say, for me, incredibly inspiring to get to listen to.
You know what's the crazy thing, Robbie? Jack actually told me about this case, but I totally at the poolside, and yet I forgot about it and still got it wrong. Anyways, take care, everyone. Have a lovely day. Bye.